Hello everybody, welcome to this session on approach to diarrhea. I will cover it in two parts. In this session, I will discuss clinical evaluation, and in part 2, I will cover investigations and treatment. So let's start. So diarrhea is among the most frequent reasons adults seek care across emergency, inpatient, and ambulatory settings. It spans a spectrum from self-limited illness to presentations with hemodynamic compromise and sepsis. The differential is broad, and because etiologies cluster by context, for example, community versus nosocomial, travel versus non-travel, immunocompetent versus immunocompromised, our initial framing matters. So clinicians must rapidly determine severity, dehydration risk, and red flags like bloody stools, high fever, severe abdominal pain, and also consider public health implications. Appreciating the prevalence and variability of presentations ensures we neither minimize a serious disease nor over-investigate benign self-limited episodes. The evaluation should proceed in reproducible sequence, which includes targeted history, for example, duration, frequency, stool character, exposures, travel, antibiotics, and then focused examination, for example, volume status, features of any peritonism, and selective testing guided by the risk and severity. Accordingly, management must be individualized, giving importance to oral rehydration, reserving antimicrobials for high risk or invasive disease symptoms, and avoiding antimotility agents in dysentery unless appropriate antibiotics are given. A systematic approach reduces diagnostic error, reduces unnecessary laboratory investigations, and aligns therapy with the most likely pathophysiology. So tailoring is essential. The same symptom labeled as diarrhea can represent distinct mechanisms requiring distinct interventions. So today's session centers mainly on acute diarrhea in adults. I will emphasize decision thresholds for stool testing, indications for empiric therapy, and recognition of high-risk hosts like older adults, immunocompromised persons, inflammatory bowel disease, or pregnancy. I will not cover the pediatric algorithms here or chronic diarrhea in detail today, though many principles overlap. The focus reflects mostly viral or toxin-mediated disease, with bacterial etiologies dominating severe cases and a constant need to balance stewardship with timely, appropriate care. So, diarrhea remains a leading global cause of morbidity and mortality. From a population health perspective, diarrheal disease remains a top contributor to morbidity worldwide and a preventable cause of death. Moreover, the biology underpinning mortality, dehydration, electrolyte derangements, and invasive infections remains universal. So understanding this burden sharpens our commitment to early recognition of severe illness and meticulous fluid management, also adherence to infection prevention practices to interrupt transmission chains. So, what is the definition of diarrhea? Operationally, diarrhea is defined as 3 or more loose or watery stools in 24 hours, or an increase in usual frequency with decreased stool consistency for that individual. The qualitative descriptor, loose or watery, matters. Form, not just frequency, distinguishes diarrhea from normal variation or irritable bowel patterns. So clarify timing, abrupt versus insidious onset, peak frequency, nocturnal symptoms, and associated incontinence. The practical definition enables consistent research application and clinical triage, ensuring that subsequent decisions, testing, isolation, or return to work advice are anchored in a shared understanding. Pathophysiologically, diarrhea reflects net water excess in the lumen due to one or more mechanisms. Firstly, osmotic load, for example, carbohydrate malabsorption, or secretory drive, like enterotoxins increasing cyclic AMP or cyclic GMP exudation from mucosal inflammation, and motility disturbances reducing contact time. Small bowel processes typically produce large volume watery stools. Colonic inflammation produces frequent small volume stools with blood or mucus. So recognizing mechanism from clinical phenotype guides therapy. Oral rehydration leverages intact sodium glucose co-transport, while anti-motility agents are avoided in invasive disease given the risk of worsening toxicity. Regarding classification according to duration, we can actually stratify diarrhea according to duration. For example, acute diarrhea persisting less than 14 days is most often infectious or toxin mediated. Persistent diarrhea, when diarrhea persists more than 15 days but less than 30 days, raises the likelihood of protozoal or post-infectious functional changes. And if diarrhea persists more than 30 days, it is called chronic diarrhea. So chronic diarrhea shifts attention to non-infectious etiologies like inflammatory bowel disease, microscopic colitis, malabsorption, endocrine causes, or medications. So now you can understand diarrhea can be watery or inflammatory. Watery diarrhea generally indicate a small bowel involvement with preserved mucosal integrity. And you can think of norovirus or enterotoxigenic mechanisms. For example, Clostridium perfringens, preformed staphylococcal or Bacillus cereus toxins. Also consider cholera in specific contexts. These conditions often lack high fever or severe abdominal tenderness and seldom produce occult blood or fecal leukocytes. So management prioritizes oral rehydration, cautious symptomatic therapy, and dietary adjustments. In these cases, antibiotics offer marginal benefit except in defined scenarios. For example, severe traveler's diarrhea or cholera. Now, a little bit about inflammatory diarrhea or dysentery. So, dysentery practically signifies colonic mucosal invasion or cytotoxin mediated injury, producing fever, cramps, tenesmus, and visible blood or mucus in stool. Pathogens include Shigella, Campylobacter, non-typhoidal Salmonella, Shiga toxin producing Escherichia coli, and Entamoeba histolytica in relevant epidemiology. The phenotype mandates reconsideration of anti-motility agents and prompts targeted diagnostics, notably Shiga toxin testing in bloody diarrhea. Here, the calculus for empiric antibiotics shifts, particularly in high-risk hosts or severe disease, balanced against the contraindication of antibiotics in suspected STEC due to hemolytic uremic syndrome risk. So accurately sorting watery versus inflammatory patterns is the pivot for stewardship and safety. Watery or non-severe cases rarely need testing or antibiotics. Inflammatory cases justify earlier stool diagnostics and consideration of empiric therapy when severity or risk profile warrants. This simple taxonomy also affects isolation decisions, public health notification, and patient instructions regarding red flags. Now, a little bit about etiology. In acute adult presentations, definitely infectious etiologies dominate. Viruses overall are most common in mild disease. Bacteria account for a greater proportion of severe cases, and protozoa emerge with persistence, travel, or specific exposures like daycare or recreational water. So appreciating these distributions informs pretest probability. For example, a brief vomiting predominant illness after a shared meal suggests toxin-mediated disease. High fever and tenesmus suggest invasive bacteria. Subacute watery diarrhea after mountain stream exposures suggest giardia. This probabilistic framing prevents indiscriminate testing and focuses on the organism that matter in the context. Regarding non-infectious causes, we must remember that not all that presents as gastroenteritis is infectious. For example, medications, metformin, proton pump inhibitors, magnesium, antibiotics, alcohol, and laxatives are frequent culprits. Ischemic colitis can mimic infectious dysentery in older adults with vascular disease. Inflammatory bowel disease may first present as acute bloody diarrhea, and microscopic colitis causes watery diarrhea, especially in older women. Endocrine and malabsorptive causes like thyrotoxicosis, adrenal insufficiency, bile acid diarrhea, pancreatic insufficiency round out the list. So Etiology depends on duration, exposure, and host factors. The who, where, and when refine the differential. Duration stratifies mechanisms. Exposures, food, water, travel, animals, sexual practices, antibiotics, or healthcare contact point to specific pathogens. Host factors, for example, older age, pregnancy, immunocompromised status, inflammatory bowel disease, cardiac disease. These conditions elevate the risk and lower thresholds for testing, admission, and empiric therapy. So, what are the common infectious agents? Infectious agents can be viruses, bacteria, or protozoa. Viral pathogens are responsible for most of the community-acquired acute diarrheal illness. Norovirus is the most frequent culprit in adults, known for its rapid onset, short incubation period, 12 to 48 hours, and outbreaks in closed settings like schools, nursing homes, or cruise ships. On the other hand, rotavirus, although now decreasing due to vaccination, remains a concern in unvaccinated adults or institutional outbreaks. Adenovirus and astrovirus contribute sporadically, especially among the immunocompromised persons. These viral infections are self-limited, requiring supportive therapy only. So early recognition prevents overuse of antibiotics and unnecessary investigations. Now, bacterial pathogens dominate severe or invasive diarrheal syndromes. Non-typhoidal salmonella or Campylobacter jejuni are common after poultry or undercooked meat exposure. Shigella often affects closed communities and daycare settings, while enterotoxigenic and enterohemorrhagic E. coli appear in travel-related and foodborne outbreaks. Clostridium difficile is distinctive. It follows antibiotic use or hospitalization and can range from mild illness to fulminant colitis. These bacterial causes require judicious stool testing, not empirical coverage for all. Differentiating invasive from non-invasive bacteria helps determine when antimicrobial therapy is both indicated and safe. Protozoal diarrhea is classically associated with persistence or exposures, travel to endemic regions, contaminated water, or immunocompromised status. Giardia lamblia presents with bloating, foul-smelling stools, and weight loss. Cryptosporidium and Cyclospora often follow waterborne outbreaks. Entamoeba histolytica causes dysentery and hepatic abscesses in endemic areas. These infections are diagnosed through ova or parasite microscopy or antigen testing, but repeated sampling may be required due to intermittent shedding. Recognizing the shift from bacterial to protozoal likelihood after 2 weeks is essential for rational testing and effective management. Now some epidemiologic clues. Foodborne diarrheal illnesses cluster temporarily and geographically. Think Salmonella from poultry, Campylobacter from undercooked meat, or Staphylococcus aureus toxin from inappropriately stored food causing vomiting within hours. Waterborne outbreaks, for example, Giardia, Cryptosporidium, often involve municipal failures or recreational lakes. Travel history is equally revealing. For example, enterotoxigenic E. coli or Shigella in South Asia, Cyclospora in tropical produce. So documenting onset after travel guides, empiric coverage, and public health reporting, reminding us that clinical epidemiology remains as powerful as any molecular panel. Occupational and environmental exposures narrow differential possibilities. Daycare workers or parents risk Giardia or Shigella. Animal handlers may acquire Campylobacter or Salmonella. Unpasteurized dairy carries Listeria risk, particularly in pregnant women. Raw seafood raises suspicion for Vibrio species. Even subtle details like a pet turtle in the home can be epidemiologically decisive. These environmental cues are integral to prevent recurrent or clustered infections linking bedside medicine to public health. And antibiotic use or hospitalization. So the modern nosocomial paradigm has made Clostridium difficile the archetype of healthcare associated diarrhea. Risk increases with recent antibiotic exposure, prolonged hospitalization, chemotherapy, or immunosuppression. Unlike community acquired diarrhea, C. diff often presents with fever, leukocytosis, and characteristic foul smelling stools. Testing is indicated only in symptomatic patients with more than 3 unformed stools in 24 hours. So recognizing this entity early allows infection control measures like contact precautions, environmental disinfection, and prevents inappropriate use of anti-motility agents. The clinical context rather than stool appearance alone is the key diagnostic clue. Now, clinical evaluation when to investigate. As we can see, most cases are self-limited. No, no tests needed. Most acute diarrheal illnesses resolve spontaneously within 72 hours. Uncomplicated, watery, afebrile cases do not require stool cultures, PCR panels, or blood tests. Overtesting leads to incidental findings, non-pathogenic organisms, or asymptomatic carriers that confuse management. The clinician's judgment is the best, reserved for identifying exceptions. Dehydration, comorbid illness, or systemic toxicity. So emphasizing clinical observation over reflex testing aligns with antimicrobial stewardship and reduces healthcare costs without compromising patient outcomes. If severe, prolonged, or systemic features are present, stool testing and broader evaluation become necessary when the illness crosses severity threshold. For example, fever more than 38.5 degree centigrade, bloody stools, severe abdominal pain, orthostatic hypotension, or persistence beyond 7 days. Such features raise suspicion for invasive bacterial infection, inflammatory bowel disease flare, or ischemic colitis. Laboratory evaluation may include complete blood count, electrolytes, renal function, and targeted stool studies. The guiding principle is test when results would change management, not merely to confirm what clinical trajectory already predicts. Now, always look for signs of dehydration, sepsis, and comorbidity. It is vital. Volume depletion remains the most immediate threat in acute diarrhea. So evaluate mucous membranes, capillary refill, orthostatic changes, urine output, and mental status. Tachycardia or hypotension signals significant fluid loss. High fever or rigors suggest invasive disease or bacteremia. Also consider comorbidities like cardiac, renal, or immunologic comorbidities that magnify the impact of even modest dehydration. Early recognition of these systemic signs directs appropriate trials. Oral rehydration in mild cases, intravenous resuscitation or hospitalization in severe cases. So some key historical points. First is duration, stool frequency, color, volume, and order. So precise characterization of the diarrhea provides powerful diagnostic clues. Sudden onset, profuse watery stools point toward secretory or viral causes. Progressively worsening or nocturnal diarrhea suggests inflammatory or osmotic process. Pale, greasy stools indicates fat malabsorption. Malodorous, frothy stools favor giardia. So quantifying frequency and volume allows assessment of dehydration risk. Patients' perception often underestimate severity. So clarifying stool number and timing helps guide decisions about testing and rehydration. This level of detail distinguishes a structured medical history from a casual clinical note. Now, regarding associated symptoms refine the differential diagnosis. For example, fever implies inflammation or invasion. So consider Salmonella or Campylobacter. Cramping abdominal pain suggests colonic involvement. Tenesmus indicates rectal irritation. Chronic weight loss raises malabsorption or neoplastic causes. Vomiting preceding diarrhea suggests toxin ingestion, whereas diarrhea preceding vomiting suggests enteric infection. The constellation and chronology of associated features often pinpoint pathophysiology before labs are even drawn. A thorough symptom inventory thus provides both diagnostic and prognostic information. And don't forget about exposure history, because exposure history translates clinical reasoning into microbiologic hypotheses. For example, antibiotic use or hospitalization raise C. diff or Clostridium difficile suspicion. Travel invokes enterotoxigenic or invasive bacterial diarrhea. Household contacts point toward viral or parasitic spread. Animals and reptiles implicate Salmonella. Recording this information systematically ensures that when stool testing is ordered, it is targeted, specifying which pathogens to culture or which panels to request. This step connects bedside history taking directly to laboratory efficiency and increases the possibility of identifying the organism. Now, about character of stool. So, small bowel processes produce large volume watery diarrhea with cramping and bloating, often without blood or high fever. The stool is typically pale, copious, and less urgent. Etiologies include viral enteritis, enterotoxigenic E. coli, Vibrio cholerae, and malabsorption syndromes. Because absorption occurs primarily in the small intestine, damage or secretion here results in high volume losses, with dehydration as the main threat. So recognition of this pattern guides priorities, for example, fluid replacement over antibiotics, and explains why many such cases are self-limited with supportive therapy. In case of colonic involvement yields a very different picture. Frequent low volume stools with urgency, tenesmus, and visible blood or mucus. Fever and systemic symptoms are more common. Pathogens include Shigella, Campylobacter, and Salmonella, as well as Entamoeba histolytica in endemic areas. These are inflammatory processes, and antimicrobial therapy may shorten disease course or prevent complications. The hallmark difference, painful, bloody, small volume stools, alerts clinicians that stool testing and possibly empiric antibiotics are indicated. So this distinction, small versus large bowel, serves as a non-invasive localization tool. It predicts which mechanisms predominate, secretory or inflammatory, and which organisms are plausible. This localization informs both diagnostic and therapeutic decisions. Secretory small bowel illnesses rely on fluid management. Inflammatory colonic illnesses may require antibiotics and monitoring for complications such as toxic megacolon. So, after history taking, next important step is physical examination. So, during physical examination, assess the hydrational status. So, assessment of volume status is the cornerstone of physical examination in any patient presenting with diarrhea. Check mucous membranes. Dryness indicates extracellular fluid deficit. Skin turgor, while less reliable in older adults, can still provide supportive evidence. Orthostatic blood pressure or pulse changes reveal early hypovolemia, while decreased urine output is a sensitive marker of renal hypoperfusion. So clinicians should quantify these findings objectively. So if urine output less than 0.5 ml per kg per hour or orthostatic pulse rise more than 20 beats per minute suggests clinically significant dehydration. Remember, correction of volume status often determines outcomes far more than etiologic therapy in acute diarrheal illness. Next is abdominal examination. So a meticulous abdominal examination helps differentiate uncomplicated diarrheal disease from surgical or inflammatory emergencies. Distension and tympani can indicate ileus or pseudo-obstruction, secondary to usually Clostridium difficile or toxic megacolon. Localized tenderness or rebound tenderness raises suspicion of ischemic colitis or perforation, while generalized guarding suggests peritonitis. In severe or immunocompromised patients, subtle findings like mild rigidity or tenderness may herald fulminant colitis. Palpation should be gentle but systematic, assessing for hepatosplenomegaly, which could suggest systemic infection or amoebic involvement. Always correlate tenderness pattern with stool characteristics and systemic features to guide imaging or surgical consultation. So always look for systemic toxicity or altered mental status, because systemic assessment extends beyond the abdomen. Fever, tachycardia, hypotension, and confusion signal systemic toxicity, requiring prompt intervention. Altered mental status, particularly in older adults, may be the earliest manifestation of sepsis or profound dehydration. Peripheral signs like cold extremities, mottling, delayed capillary refill indicate hypoperfusion. These findings indicate the need for immediate resuscitation, and a truly comprehensive examination can ensure that the initial focus remains on stabilization before laboratory investigation or antimicrobial consideration. So today we have covered different aspects of diarrhea, including presentation history and physical examination. In part 2, I will discuss about investigations and treatment. So please keep tuned till then and press the bell icon and subscribe to my channel if you find it helpful. So thank you everybody for your patient hearing. Thank you all. See you next.